As good as advanced IOLs have become, I think we can both agree not every patient needs an advanced IOL or is even necessarily an ideal candidate for those IOLs. And I think it comes down to a couple things. One, can we meet the patient's expectations if we're using an advanced IOL? And two, what is the patient's anatomy? And so when I look at a patient and I'm trying to assess what they would do best with, if I'm sensing that their expectations are really, really high, this is a patient who wants to be completely out of glasses, they want zero side effects, they want a guaranteed, I want you to guarantee me 2015, 2020. These are patients maybe where the advanced lenses will not necessarily deliver because as good as they are, we know that there's no lens that's as good as the natural human crystalline lens we're born with. And so if their expectations are through the roof and through our counseling and through our discussion, if we can't either lower those expectations to a more realistic level, I think those are cases where maybe they would do better with a standard lens implant.
I think you make a really great point about patient personality and the unrealistic expectations. We spend a lot of time during our chair time discussing with patients that perfect goals, quote unquote, perfect goals is what we most definitely aim for, but it may not be possible in every eye. And I think the eye anatomy or ocular findings are often limiting factors as to which lens we can offer patients. First and foremost, we look at the ocular surface. One of the main reasons patients with multifocal lenses, for example, are unhappy is if they have ocular surface disease. And we spend a lot of time assessing that ahead of time before offering a patient multifocal lens. If a patient has chronic dry eyes, if they've had to have multiple treatments to get the ocular surface optimized, that is a patient who's going to continue to have chronic dry eyes and may not be able to reap the benefits of a multifocal lens, and worse, could potentially have worse visual aberrations as a result of it. If a patient has other corneal comorbidities, such as epithelial basement membrane dystrophy, pterygia, keratoconus, ectasia, pellucid marginal degeneration, if they're post-refractive, these are patients to whom we are going to limit the options we'll offer. Really, there's nuances about those decisions, but patient with EBMD, we will do a corneal polish ahead of time, but again, that corneal surface is not pristine, and we'll have to think about the impact it'll have on the quality of their outcomes if they were to have a multifocal lens, as an example. Now, the Vivity or the non-diffractive extended range lens would be a reasonable option for a patient with corneal findings as long as their central 3 millimeter of the topography is essentially normal. Let's talk about keratoconus patients. A keratoconic who has severe keratoconus would not be a great candidate for many of the premium lenses except for potentially the IC8, but even that lens has its limitations. But then there are keratoconic patients who have astigmatism that's essentially bow tie in the central 3 millimeters of their corneal topography, for whom we would consider, would you agree, a toric lens or a light adjustable lens for those patients. And lastly, let's move towards the back of the eye. Patients with macular disease, if they have macular degeneration, epiretinal membrane. We detect these on our exam as well as using macular OCT on all our cataract patients to be sure that the macula is pristine, simply because, again, any comorbidities, anything that could potentially diminish the quality of vision that patient can get would limit our enthusiasm in offering a premium lens to them for multiple reasons, one of which would be the investment of time and money that that patient will make in that premium lens elevates their expectation. And if the result is limited by other comorbidities, again, we could potentially lead to a patient who would be unhappy with the choice they made with that lens.
Yeah, I think those are all fantastic points. And maybe just one final key element I think both of us really pay close attention to is what is the patient's visual acuity? And this is true for whether we're thinking about cataract surgery, refractive lens exchange. If a patient comes in and their best corrected visual acuity is 20/20 or even 20/15, I really pause when thinking about whether or not they would do well with an advanced lens, because we know that by virtue of how these optics of multifocal or extended range lenses work, there can be a slight reduction in contrast sensitivity, and we see that with the defocus curves. That's a patient, maybe an emmetropic presbyope, for example. We use a multifocal and they were best corrected to 2015. They're out of glasses, but now they're like, gosh, I feel like my distance vision was better before surgery. And that's a situation we want to avoid. And so if I see that a patient's 2015 or 2020 best corrected, I'll have a long conversation with them about what are your desires and how bad do you really want the range of vision at the expense maybe of a little visual acuity. With cataract patients, it's not a big deal because their best corrected visual acuity has dropped, so that's not really something we have to worry about. But for those patients, those emmetropic presbyopes, 2015, 2020, that's another thing worth considering. So I think you brought up a lot of fantastic points. All three things, patient expectations, patient anatomy, and patient visual acuity, these are all reasons why maybe an advanced lens option, as good as it may not be the best option for the patient.